Dear friends, let's move on to the panel discussion. We have our own Mr. Joy Chakraborty, who's going to be moderating the session, and he needs no introduction. However, I'm going to introduce him today. So, he is the COO of the PD Hinduja National Hospital and Medical Research Center, Mumbai. And with him, the panelists are going to be Ms. Vidya, who's the Manager Quality at Apollo Proton Cancer Center, Chennai, Dr. Anuradha Pichumani, Executive Director of the Sri Ranga Hospitals, Chengalpattu, Dr. Sudeshna Ganguly, Medical Director, Teladoc Health, Kolkata, Dr. Shalini Agarwal, Professor of Radiology, Department of Radiodiagnosis at BD Sharma Postgraduate Institute of Medical Sciences. We have Dr. Nesha Ajit Nair, Consultant Quality and Patient Safety from AGM Medical Affairs. She's the AGM of Medical Affairs and Quality from Dubai. We have Dr. Santhosh Kumar, Director Administration, Ruben Memorial Hospital, Patna. They are going to be joining as panelists, and we are going to have a very exciting panel discussion today. Before I hand over to Mr. Joy Chakraborty, I'm going to put this thought to all the attendees. We wish to know from all of you as to whether you are ready to start the Patient Advisory Council. If you are ready, please put up your name, your hospital in the chat box. We'll be very happy to follow up and to also learn from you the progress of the Patient Advisory Council. Best wishes to all of you. Request all of you to join this great initiative. Put up your name, your hospital, and we'll be very happy to hear from you. Over to you, Joyce, sir.
Good evening. Thank you, Dr. Lalu and Kaho, for giving me this opportunity to moderate this session that it's setting up PAC, Patient Advisory Council, is good for hospital. I think for last 1 hour, the discussion what has gone through that very clearly states that there is going to be no one on the other side, but nevertheless, we need to talk about the kind of pros and cons and the kind of framework to set up for setting up a patient advisory council. If you go back and if you look at the healthcare sector history, that the introduction of the patient advisory council, I go back in 2007, 2008, when there was an incident with the patient, unpleasant incident in Cleveland Clinic, where the hospital was not doing that well at that point of time, and they were suffering because of heavy loss, huge kind of cut from the insurance company for reimbursement of their treatment cases, and because of that, the management was very serious that how to turn it around. And at that time, they introduced first time globally the concept of patient experience. And along with patient experience, one of the integral part what they added was this patient advisory council. And now history, all of us will know where this Cleveland Clinic stands today globally in terms of healthcare delivery, healthcare provider. And as per the global rating, US News and Ranking, it stands number 2 in US, and some of the departments they rank number 1. So of course, one part of it is clinical outcomes and all, but the second part, the success has come because of a tremendous effort they have taken in terms of ensuring that patients have become part of their journey, part of developing their facility, process, system, policies. So it is a very good success story for all of us. And with that note, I'm going to start and going to ask, I don't see Dr. Santhosh Kumar has joined. His video is not on. So
yeah, I'm there.
Yeah. So I'm going to start with you that when we see a good example, a story of success on this line of our topic in international scenario, I want to ask you, what is your view and opinion in deploying or establishing a patient advisory council in context of Indian hospital, Indian environment? Because very often you say our market may not be matured, our patients may not be matured, we may not be adequately prepared to handle the kind of storm we are going to face in terms of empowering them, in terms of giving them this kind of power to work with us. So with this background, I want to ask you that what is your view on this? So over to Dr. Santhosh Kumar.
So thank you so much for having giving this opportunity for sharing my views on this important topic. So last 1 hour and so we have heard our learned speakers about the benefits of PSC and how to implement the PSC in our organizations. And definitely, as we have heard that Patient Advisory Council in the context of Indian hospitals also will be very valuable initiative to improve patient centeredness and all that, despite all the different challenges they face. In fact, it will help them to demonstrate that commitment to patient-centeredness is there to ensure patient voices are heard, and of course, those voices are utilized for improving the uh, quality of healthcare services offered by their level. In fact, already a lot of healthcare experts, we Dr. Nagendra, Dr. Alex, and all, have started saying, and we have had informal discussion that PSC is going to be one of the key differentiator for the hospitals, and that's why probably all the bigger hospitals including yours have taken up on a priority basis, and they have taken lead in establishing this. As you also said, that movement started in Cleveland Clinic. WHO started in 2012 or 13, this Department of Patient for Patient Safety. But major challenge there is, of course, the know-how concept about the successful examples are not there, especially in the rural town, rural villages, shortage of resources, few Indian cases were there. And of course, there's a lack of motivation. We always talk about this, we started talking about patient safety, patient for patient safety, and a patient advisory council with our doctors. They said, look, if we start uh, kind of engaging the patient with or all these activities, the patient will learn our mistakes and they will create more problem with us. So that distrust is there. But despite all these challenges, I'm glad that Kaho has taken up this initiative process of developing and set kind of new guidelines for Indian context, keeping Indian problem and challenges we face. So in nutshell, I will say yes, this whether it is Indian context or the problems of patient care is global. It's not Indian and all that. But the only thing is the implementation and challenges are different, and therefore our way of implementation has to be thought of differently. And glad that Kaho is taking this initiative. Thank you.
So you are right, Dr. Santhosh Kumar, that COW has taken so many pioneering steps and initiatives to make Indian healthcare safe, better, and improving quality aspects. So this is another thing, and I'm happy that the kind of participation is happening in this platform and commitment is getting garnered for the September event. I'm sure many more who are not present here going to be inspired and going to take the path in this direction to create this patient advisory council. But nevertheless, amongst us, we have right now someone who has already embarked into this journey. And I must tell you that I'm going to ask this question to Dr. Anuradha Pichumani. She is from a hospital in Chengalpet. It is not a metro city or not a big town, but in that location, that area, she has shown the interest and she has embarked into the journey of creating the patient advisory council in her hospital. So my question to Dr. Anuradha, that what inspired you even before this initiative of Kaho to think about it and launching this patient advisory council in your hospital? So over to Dr. Anuradha. You have to unmute yourself.
Yeah. Thank you, Mr. Joy, and thanks to Kaho for this great opportunity. It's a wonderful day of initiating this whole patient and family advisory committees here. So, related to my own journey, our hospital is, as you told, it's Sriranga Hospital. It's a 32-year-old hospital now. This is our 33rd year, and it is in a tier 2 town. And we cater more to the village and semi-urban, semi-rural population here. So we started our quality journey in the 2010, and then we were more into quality and safety projects the last 10 years. And we are into person-centered care in our hospital, because our practice is more of a family-oriented practice for our own patients, group of patients. So I wanted to implement it from theory to practice. Rabina, you can do it later in the next round. So I wanted to, we started with co-designing some projects with the patients. And that's the way I started looking at various projects on experience-based co-design. And we did the first project, and I presented it in ISQA, in the ISQA International Conference in South Africa. And it won the one of the quality competition prize from Southeast Asia. That was the first time they ran a competition there. And this again motivated me to improve on this various projects where we are going to involve patients. So we started redesigning care from profession-centered to person-centered, asking patients what matters to them. And again, it is more of a diagnosis-specific pathway to a patient journey now. And then as I started working on in these projects, then I was selected by ISQA for the Person and Family Centered Advisory Committee. And we started doing various programs with the PFCAC projects also. And that's how I was getting involved in various patient groups. And then we, through KAHO and with Nadira ma'am and Mr. Somital, Vijay sir and Lalu, we started this Patient for Patient Safety Foundation. And now we are implementing various projects, which I'll be elaborating further. We have started our own Patient and Family Advisory Committee, where I am the chair of this committee. We have facilitators, we have patient experience officers, we have a patient safety officer also as part of this committee. And and all the patients who are members of this are very happy and motivated to do these projects. So that's how this again inspires me and motivates me to work with them. Thank you so much.
Thank you, Dr. Anuradha. I think your story is going to inspire many of us, those who are attending today and probably will be hearing about it tomorrow. So I move on to my next panelist, Dr. Vidya Mani. Ms. Vidya Mani, she comes from a little different background, from a corporate setup, and where it is in a, the kind of patients, the kind of patient relatives they handle are quite different, I think more demanding as per our terms. And sometimes we say that it may not be right for them to expect certain things to happen. But nevertheless, I'm happy to hear that they have also embarked into the journey of introducing this patient advisory council. So what one side is that we are creating this to make better patient experience. But the question, I'm going to flip it here, that what value have you observed that when you have thought about it, when you have undergone this whole process, what value you have got, and what are the specific aspects have motivated you to get involved in forming this particular body in your hospital? Over to Ms. Vidya Mani.
Thank you, Joy sir. Thank you, Kaho, for the opportunity extended. Increasingly, healthcare organizations are now adopting towards this patient advisory council. It is more used as a strategy for engaging with the patients and their families in order to enhance the patient experience. So that is probably one reason why hospitals are going in for PACs. But when it comes to the values that we observe when we have PACs within our system, I would just like to highlight on three main points. Number one is it serves as a mechanism for process improvement, because when you have these PACs in your organization, it helps to seek and learn from patients and their families' perspective. Let me just give you an example. For example, like most of us have processes set forth for your registration, your admission, or your daycare procedures, while your internal quality teams would be able to give you an overview in terms of how things are going on. But the ground level perspective, the real picture is something that you will get in from your patients or the families that have availed the services in your organization. So while we get the PACs in our hospital, it is going to help us understand what are the areas that we could improvise on and any interventions that we could do to simplify the overall procedure and make it more patient friendly. So that is number one value, I would say. Number two, I would say is PAC also helps us to identify the training needs within our organization. There's a learning that comes from every interaction that we have with patients and their families. So PACs do serve as a method to identify the training needs. For example, when we had initially tried to understand how effective our pre-op counseling is for elective surgeries, it does give a broader picture in terms of what is it that the apprehensions that a patient has, and how else we could have trained our staff to communicate with the patients. So I think the second value in terms of having a PAC is to help to identify the training needs. And the third, the most important thing, which we've heard it from all the experts in the beginning of the session, is it is important that we understand that a well-informed patient is going to be a happy patient. So the patient advisory councils are actually a strategy by which you can engage your patients, their families, keep them informed on the reasons why we are carrying out certain things the way it has to be done. And more importantly, similar to what Gracie ma'am had said, having them involved in shared decision making, it is definitely going to help them comply to the treatment advice, and definitely going to help us render a safer care. And the fact that PACs are going to be helping the organizations understand our patients and families better, and ensuring that the service experience is going to be enhanced, I think that is the reason why organizations go for PACs. Thank you, sir.
Thank you, Vidya. And I think you have touched upon a very important thing. And as you quoted, Mrs. Gracie Mathai has touched upon the point too, that you need to get your patients as a partner in your decision making. They should equally hold the responsibility of this decision. So shared decision making, which is going to be very important for today's age. Patients who are more empowered and they are more educated about what is happening with their health, with their treatment. So thank you very much. I will move on to my next panelist, and Dr. Shalini, and she is coming from a little different background. And I remember way back in 2005, 6, 7, 8, at that time, we got first time NABH in this country, and it was considered that it is going to be for some of the elitist class of hospitals who will go for this accreditation and will get themselves accredited. However, we have been proved wrong when we saw some of the state government hospitals, which started with Gujarat, then Tamil Nadu, they have gone in a big way and they got themselves accredited. So similarly, in this scenario, she is representing, as you have seen already in the introduction, a private, a government establishment, a medical college, a hospital, where the patient load, we know the kind of they face, they undergo, and there to manage the situation, I think we need to have a much better patience, much better ability, a different kind of agility. So when the environment is completely different and she is representing that sector, we'll be very keen to know that, what are the action points you consider for your kind of setup need to be taken before getting into this journey of setting up this similar kind of body, patient advisory council, in a hospital and setup like yours. Over to Dr. Shalini. You have to unmute yourself.
Thank you so much for this question, and thank you so much, Kaho, for this opportunity. I have to first of all say that this has been my dream for a long time, because I'm a clinician dealing with patients every day, and somehow their experience is just not good. I am breaking my back trying to give them the best of treatment, and somehow they are not satisfied. And I think the reason is that they don't understand what is happening in a hospital. They feel that they're not getting the best of management that they deserve. So hence, a patient advisory council is the need of the hour. As far as the action points are considered, we have to start understanding, we have to understand that there are certain customer touch points, and we have to, take advantage of them, like the registration counter in the morning. There they can be given some educational material. Then at the time of collecting their reports, the lab reports, then at the time of collecting their radio diagnosis reports, they can be asked about how the whole process of getting the investigation, how did they feel about that investigation. Then at the point of discharge, they can be asked what was their entire experience. Right now, we have every patient is heard in our hospital, in spite of the fact that we are a 2,000 bedded hospital. But the means of the patient redressal is either the patient goes and complains to the HOD, or he goes to the director, or he goes to the medical superintendent, or he is filing an RTI report, or he's complaining on the CM window. Meaning it's like, it's not an interaction, it's the patient is complaining and somehow you don't have the means to explain to the patient why a certain situation happened. So it can be done in a government hospital. Another point that I want to highlight is that in tier 2 cities, tier 3 cities, the literacy level is low, and we have to take that into account while interacting with them, while involving them in their own care. So that's one. Even if you explain to my patient, maybe they'll not understand. So we have to find ways and means of making them understand that this is the most that can be done, and as per the literature. So I feel that we have to have people at these touch points who will either ask for a survey or ask them for their experience, and then get together and put it all together in the form of an PAC.
So thank you, Dr. Shalini, and I can only tell you something, that you consider this is a major challenge or kind of problem you are facing in a government setup. But let me quote you a report which came out through one of the big consulting firm in 2018, where the patients and their families were interviewed by them, and they look at the result, and you'll be surprised to believe that 53% of the respondents, they told that they don't trust their providers.
Yes.
Why this has happened? Because probably the kind of bonds, the kind of bridge which was supposed to be developed and supposed to be, done between the patient and the hospitals, it has not happened, and each one of us are responsible for doing that. So thank you for your viewpoints. And now I move on to my next panelist, and she comes from a different geography. So we spoke so far about India, we spoke about rural India, government sector, private sector, but the question is now to the panelists representing the international arena, and where the accreditation is part of this system, where accreditation system has a part where you need to have patient, this particular council as an integral part of it. So going to ask the question to Dr. Nesha Nair, that how does compliance and international accreditation, what you face, drive you towards this patient advisory council, the environment where you need to commit this, and probably additionally you can tell us that how these initiatives are getting shape within this particular structure where you are working and you are representing. So over to Dr. Nesha. You have to unmute yourself.
Sorry. Thank you, Joy, sir, for this question, and thank you, Kaho, for this opportunity. So today, internationally, the language and concepts of patient partnership and empowerment are included more frequently in all the healthcare discussions at the state and national level policies. There are federal initiatives are also being encouraged for the hospitals to create ways for patient and families to collaborate with healthcare professionals. So I would like to share a slide where we have, two landmark reports Is my slide visible?
Yeah, now it is coming up. Yeah, it is visible.
So there have been two landmark reports on how the partnership of patients initiative.
Slideshow mode. Can you put it on a slideshow mode?
Just a minute. Yes, is it visible?
Yeah.
Okay. So as I was mentioning, there have been two landmark reports on how the Partnership for Patients initiative, which is funded by the US government, has set expectations within the hospital networks to include matrix related to discussing patient and family partnership roles in care planning, plus creating opportunities for them to participate on the hospital committees, as well as governing and leadership boards. So this is the report from New York for the New York State hospitals, and the other one was related to, it was a national study for pediatric children hospitals in US. So it gives a beautiful roadmap how the journey is taken over since so many years and how compliance is being looked into based on the engagement in the PACs. Now coming to Canada. It has a national quality and patient safety framework, which includes 5 goals, with people-centered care being the first one. This means that the patients and providers, they work together to design all aspects of care. And if we read further, it recommends on forming patient advisory councils. So further, we have Canadian accreditation program. We have adopted it for a few of our hospitals. So this program encourages governing bodies to include patients as members whenever possible. And the governing body must prioritize creating meaningful partnerships with patients and families. This high priority diamond level criteria requires that governing members educate themselves on the principles of patient and family centered care and ensure that the organization's culture is centered around their needs. So this is something which is, from the accreditation side. Apart from the governance standard, we also have leadership standards, which focuses on involving the patients, having a patient advisory committee, on having partnerships with the patient, taking inputs from the patients, and ensuring that the patient experience is ensured, ensuring that patient safety is ensured. So coming to the second part of the question. During our hospital, we implemented Accreditation Canada in 2 of our hospitals at Oman. I'm dialing in from Oman currently. So our hospitals, one of them is in the city, and the second hospital is a smaller hospital, one of the only private hospital in, I would say, rural areas of Oman. So it's like, beyond the mountains and valleys, and the only hospital which caters to the expats and also the national patients. So coming back to whether it can be done in smaller hospitals in rural areas, yes, initiatives can be rolled out in smaller hospitals also. So during our accreditation journey, when we first read the standards, we were in a dilemma about, how we are going to achieve this. But then thanks to our survey coordinator, Dr. Ali, he was guiding us. So then he suggested us how we can achieve this. He gave us simple examples, how we can initiate our journey. We are yet to implement a patient advisory council, but still based on the guidance, we took our first steps by involving few patients in the walkthrough of our outpatient pharmacy and medication education brochures. The response was excellent, So one of the senior citizens brought out an important note that the font of a pharmacy token is, too small to be viewed from the rear seats in the pharmacy waiting area. So now this required just increasing the font size, but the satisfaction we could give to the senior citizens was reflecting on the smiles. And when we fixed it during that same meeting, it was really, we felt excited. We thought, yes, this is something which is doable. So then further, we could address also certain more queries which came up related to discarding of the pre-filled syringes of methotrexate and low molecular weight heparin. Then our next engagement we took up was with our patients to understand if the handing direction boards were easily visible during wayfinding. And we could get recommendations on enhancing the visibility of these boards. So it required simple actions, but it had a meaningful impact on the patient experience. We also considered involving patients during the soft launch of a new facility, Aster Royal Hospital at Muscat. And based on suggestions, we made changes to the waiting area partitions. Initially, our televisions in the pediatric area would play only those Mickey Mouse and Tom and Jerry. But then, based on the feedback from parents, we changed the kid cartoon series to new ones like, the Peppa Pig, Deer Squad, etc. And now currently we are working on forming forums with patients and further inviting them to be part of one of our committees. So this has been our real-time experience, and we look forward that very soon we would be settling down, having our own PAC for each of our hospitals. Thank you.
Thank you very much. And I think you have again shared a view from a very matured healthcare market where the Patient Advisory Council has been integrated with the accreditation system, and small, tiny steps, but keeping the patient interest in the mind, the way you have designed and you have given small fonts, the example, I think it is really, this kind of small steps are really going to take our patient care in a different level, and it is going to be patient-centric, and it is going to be really appreciated by all of them. So with this, I move on to my next panelist, Dr. Sudeshna Ganguly. And, she comes from a completely different background, not as a provider as such, and not into the game, but she is like an expert consultant who are giving a suggestion and the kind of processes needs to be followed to develop this. So can you share some international perspective and various aspects of how you are implementing in international level this patient advisory council of kind of concepts? So over to Dr. Sudeshna.
Thank you, Mr. Chakraborty, and thanks to Kaho for this opportunity. I think this is an excellent platform where I can share my views. So there are two aspects to the question that you've placed to me. One is international perspective on patient advisory councils and how my organization is integrating it into its practice. So to deal with the first part of it, I would just like to go back into history a little bit so that we understand the context here. While this is, of course, a new and brilliant concept, which is now being started in the subcontinent region, as far as historically the history of PACs are concerned, this concept came into being in early 1980s. And it's very interesting how it came into being. It came into being basically in the Massachusetts General Hospital, Boston's General Hospital, for the pediatric department, where parents raised an issue that they need longer visiting hours, and they also need more psychosocial support for the children who are admitted. So for the first time, the parents, besides being caregivers or caretakers for the children, also started having an impact on the hospital policy, program, and indeed in making a difference to how the hospital is set up. This council, which was set up in Boston's Children's Hospital, continued to function for a good 5 years. And they were very instrumental in setting up the new pediatric wing for this Ivy League institution in Massachusetts, USA. Now, coming from there over the decades, internationally, the PACs have evolved. Initially, when it came into being, they only had patients as part of it. But then gradually the hospitals realized that it has to be a two-way communication. And then the clinicians, the administrators, the other caregivers, allied fields were all brought in. And that gave a more complete picture to the PACs as we now see it. But it has not been an easy ride for even the global platform. As late as 2018, the American Hospital Association, AHA has also another form, it's not just American Heart Association, there's also an American Hospital Association. And that has a survey, an annual survey, which is sent out to some 6,200 hospitals all across the United States. And in 2018, they included one mandatory question. They added one question to their 1,300 question list. And that was, does your hospital have a patient advisory council? And the data which came out from the 2021 survey, published as late as December 2022, shows us that with a response rate of 61% on the survey, the number of hospitals which have a PAC has actually gone down from 55.10% to 51.36%. So the drive to have a PSC on board is again gaining momentum internationally. So I think India is poised for this at a very strategic standpoint when the focus on including the voice of the patient has become a global reality. And it has been found very interestingly, since we've had speakers on this panel from various backgrounds, the government representation, the corporate representation. So very interestingly, through this survey, it was found that while 61% of the not-for-profit hospitals had a PSC, it is only about 32% of the investor-owned hospital who have running PSCs. It is also found that teaching hospitals have a higher rate of having PSCs as compared to non-teaching hospitals. Very interestingly, Massachusetts is the only state in the United States which requires, mandated by federal law, that 100% of the hospitals have to have a PSC. Now, coming to the organization I represent, Teladoc Health is one of the leading virtual care health providers on the international scenario. And we have a clinical footprint in 80 countries across the world, India being one of them. And in our organization, the voice of the patient is included in a big way. In fact, just to sort of give an example, that when a member, as we address them rather than as patients, we call them as members. So they are a member of the Teladoc family when they are seeking care from us. And when we are interacting with a patient or a member, however you refer to them, once their clinical records are prepared, the patients are given a chance to view them before it passes on any further. So we have essentially, that focused department which looks into this aspect of including the patient's voice into day-to-day practice. So it's a day-to-day practice to have the patient's voice represented, to have their ideas represented, to make the care patient-centric, and to have a shared understanding on what kind of care is being provided to them, why things are being done in a certain way. As I think one of my co-panelists said, that it's very essential for the patients to know that why a particular thing is being done, how they are being done. So from an international perspective, I would say that it's not only India. On a global front, the drive to have a patient advisory council is picking up momentum again. And every country, every developed nation, every nation from the developing world are now focusing on this. And as part of my organization, I'm very actively involved in this as well. And it's excellent to see that Kaho is taking this forward in India. Thank you.
Thank you, Dr. Sudeshna, and congratulations for making it happen in so many countries through your organization. And thanks for sharing the global perspective that how the type of countries, the number of countries, the type of hospitals are now willingly joining, or even through regulatory measure, it has been made mandated to some of them. It is really nice to see that movement has begun, and probably we are also going to catch up, and we're also going to talk about this in next 2-3 years to say that we started the journey and we have reached the where we are. So with this, I move on to Ms. Vidya, and very important when you run this advisory council or you involve patients, the very important part is how do you incentivize them? Like, why do somebody come and join you and help you in this thing? So according to you, how can patient participation in this advisory council get incentivized? Over to Ms. Vidya.
Thank you, Joy, sir, for that question. One thing at the start, Lalu ma'am had also insisted that the members of this PAC committee, they're all going to be voluntary members. So it is basically a voluntary initiative. So it is important that the members need to understand that the role that they play is something that is going to be adding values to the organization and not necessarily something that they get back in return immediately. So at the beginning of setting up of the PAC teams, it is important that the roles and responsibilities have to be informed to the patients too. But however, it is important for the patients to know that their opinions do count and their voices are heard. So the suggestions or the action points from the PAC will have to be shared on to them so that they will know that they have added value to the way things are being done in the organization. And once the patients see that their voices are being heard and their suggestions are being taken into account, it does keep them motivated and it does keep them engaged. So that I feel is going to be the best way by which you can incentivize them. That is going to be the best way by which you can get them engaged. So that's my take. Thank you, Joyce.
Thank you. Thank you for sharing, because there is always a question in the mind that if you involve them, how you are going to ensure that they get back something as an incentive. Like, I think the biggest incentive when someone represent that they are going to be the voice of the patients, and their voice, if it is heard, then in a larger context, the entire patient community is going to be benefited. So thank you, Vidya, for the answer. Now I move on to Dr. Anuradha. And my question that what kind of engagements and outcomes have you experienced following the establishment of the Patient Advisory Council in your hospital? Because you are one of the hospitals who have introduced, and that is also in a kind of place where you have done it, and you have done it in a very early stage. So can you just talk about the kind of engagement and outcomes after getting engaged with the patients you have seen in your own setup?
Yeah, thank you, Mr. Joy, for this. We started implementing person-centered care, and to implement person-centered care, I feel this person-family-centered advisory committee is very essential. So that's how we started implementing this in our hospital. And since you have asked for outcomes, I just created 2 or 3 slides of what we have done this last 3-4 years now. We have started asking the patient what matters to them. We started asking the professions who are going to serve the patients. And again, we started reorganizing our whole system, the way our hospital functions, involving the patients. We started making the patient as the center of the whole program. So as you see, we have these people who are our staff members. Actually, I'm sitting in their room only in this conference hall where we have had repeated programs on person-centered care. So this is our committee members here. And these are various, I have given some of them. I'm trying to give you some examples of what we have done. So we have redesigned our systems, including the patient's voice. We have done some PDSA cycles using patient members again. And I have included them in a patient journey in one of the departments where we were able to see how the system can support them in a better way. And again, our hospital has been involved in various community projects here last 20 years. So now we have included them in our community projects also, which I will be showing you. And again, for patient safety, because it's a very important thing that we include the patient and the family members. The family members are the best persons who can take care of the patient. So even in our absence or in our presence or whatever it is, because they are closely knit with that patient. So when you are going to involve them, they become the second eye or the third eye or whatever it is. So we try to involve them in the patient safety procedures. And again, we have developed certain tools to involve them in using some technology. And again, we are able to measure this person-centered care when you are going to involve them in the person and family-centered advisory council. So we have named it as Person and Family-Centered Advisory Council. Can I have the next slide, please? So we have done the whole way I see it is we are more into proactive care now. We are able to integrate the care across departments. So this is the first project which we did on experience-based course design. This was done in dialysis department. We involved the patients and the staff working in that department. And this is the co-design group which we had. So we started with the facilitator. I trained my facilitator, and then we got them to talk about their experience inside their own department. And since they are the people who are inside the department 24 hours, so they will be able to give us more suggestions than we can do. So then we created some videos with one-to-one interviews, and then we had a joint session of both of them viewing it after editing these videos. And then we asked them to prioritize what are the issues they are going to change now. And based on that whole program, we had some quick fix solution for 10. Process redesign, we did it for 12 of the issues, and organization level solutions were for 14. And we implemented all these projects, and you can see the outcomes. So patient satisfaction improved from 37 to 85 on certain aspects, whichever we had asked them for. And again, the staff were also satisfied because we had involved the staff who were working there. So again, it improved from 50 to 75. I think Ms. Nadira and all others have been talking about outcomes now, how to measure PCC. So these are the ways where you can start measuring what you are able to do and show it back to the whole group. Next slide, please. And then we moved on. I utilized the mapping patient journey process. The previous project was the one which I presented in ISQA for that, and it got selected for the quality competition also. This was next project which we did on with using patient journey. So mapping a patient journey becomes very important because you have a person and you have some goal. The person has to reach the goal. And during the process, he travels inside a hospital. So this is the patient journey, what we have. So we involve whoever you see are the patient and family members who are still with us, moving on with these committees. So they started mapping whatever they went through. And we involved the staff members also from the pharmacy, from the reception. Because when you talk about pharmacy, it's not only the pharmacy, it is through every department. They have to talk to a nurse who has to give the injection or whatever it is. So they have various experience across the whole organization. And this is the way we mapped it. And based on all their ideas, when we rebuilt our new pharmacy, we included all these ideas. There were quick fix solutions for 5, process redesign was 5, organizational solution was 15. So all these things were put up, and this is our new pharmacy, which you're able to see now. And we created a waiting area. We started putting up carts based on the suggestions. The carts were being pushed to the floors now, so that the drugs are being distributed. It is a small hospital. It's only 2 floors, but still, whatever the patient asks, we are able to do it within our limits. So patient satisfaction from pharmacy, it improved from 37 to 85%, 85.7% after we finished this project. Again, staff satisfaction also improved because they wanted some storage areas. Whatever they asked for also, we were able to do it. Next slide, please. So these are various ways where you can involve. I'm just showing you some examples. And these are some of your community projects. Even today morning, we had one of this project. The first community project is a very new one, which is the first in the whole district, maybe first in the state. It is a training program and awareness on healthy living for school students in Chengalpet district. So every school in this district, the school students are being selected, and we are involving them in the training program. And this training program, we involve the whole community, the district collector, the chief education officer of this district, the joint director of the district. And in this, we involve the PFCAC committee members. They were very happy to participate in this. I asked them to participate, give us some suggestions on what the students need. And they also started participating. They took some classes on general hygiene for this girl students, because anemia is a big issue for adolescent age. So in this way, we were able to involve them in these projects. Again, moving on, because I showed you in dialysis, labor ward, dialysis and pharmacy. Now moving on to labor ward, we have involved them to improve the patient experience. So I have involved them in doing some project called Together for Her. It is a WHO's quality of care initiative. So we get them give answers how to improve the quality of care. And again, we involve the patients in getting some experience about childbirth experience questionnaires. So it is called the CEQ, and based on whatever they have given us feedback, we were able to improve the labor ward experience. And the third part, what you see here, is the birth companion project. So for every patient, we ask them to bring a birth companion, and that birth companion is being taught. And we have started involving our PFCAC committee members who have delivered babies. So they have undergone the process of delivery, and they are able to talk to them in a better way. And I'm able to see the number of normal deliveries improving now, because they are able to help them out. And again, this is one of the cycles which we did. So we are able to show some outcome of improving the patient satisfaction from 89 to 96. And then it is being sustained at 93 to 95 now. So this is the way you start improving, making them get involved. And you were talking about incentives. We are not giving them anything. It is only the motivation which has been given by them, and they are also encouraged to participate in all this. And as we were discussing, we are going to celebrate the success of all this on in September on the World Patient Safety Day. So we need to celebrate that success, and that is a huge motivation for them when they take up these projects. Thank you so much.
Thank you very much, Dr. Anuradha, that I think you have shown that it is not a matter of discussion. You have implemented in measurable terms. You have shown that what has been achieved in your hospital can be learnings for many. So thank you very much for this proactive approach and taking this to this level in a short span of time. Now we move on to Dr. Sudeshna once again, that in the previous round you have told about so much about international experiences and the kind of framework in which it has been done. But I'm sure that it is not happening like a very easy cakewalk. It has got a lot of challenges, a lot of barriers. So can you talk a little bit about that to operate on this model of patient advisory council? What are the barriers and challenges you feel are there and you can share with us?
Thank you, Mr. Joy. It's rather interesting and intuitive that this question comes right after a success story. So there is always one wild turkey on every, council. So I'm very willing to play that role and talk a little bit about the challenges that every institution faces, whether brick and mortar or online, in establishing a PAC. So the first challenge is that a change in the cultural mindset. This differs a little depending upon the culture of a particular country. Here, I just don't mean an organization. I mean an entire nation. And if we look at the Indian perspective, for instance, India is traditionally a high power distance culture. We expect and accept a high power distance. And that exists between caregivers and patients or members as well. So traditionally, our doctors have been used to telling our patients what they need to do, how their care is being given, explain only what they would want to explain, or as far as they feel that their patients would be able to, take in whatever they are saying. There are lots of technicalities involved as well. So sometimes it's a little difficult for a non-medical person to absorb the information that's being given to them, particularly when they are in a situation of stress. Naturally, when I have a family member admitted to the hospital, I would be in a reasonable amount of stress and may not be able to process all information. So that is the framework in which we've traditionally worked. Now what is needed is a change in the mindset. Suddenly, I have to give the patient a seat at the table and discuss with them and have their voices implemented. And they will play a role in my policy making, in my decision making, and they have a right to ask questions, and I am bound to answer them. So in a way, this can be, or this is in fact, a point of resistance which needs to be overcome through proper counseling of the hospital administrators, through involvement of the clinicians. And as I think we've discussed multiple times, that we need to involve someone senior from the hospital, need not always be the CXOs or the CEOs, but someone who is in liaison with the top management and also with the ground staff as well as patients, who can actually work as a facilitator to sort of implement and improve this process. So the first challenge or the first barrier that you will come across is this. Changing the mindset, bringing up a cultural change is not easy by any means. And I think in our own ways, in our own setups, we will all face this sooner or later. So we should be oriented that somewhere we would need to explain the idea, the context, the necessity, and what is there in this for me. So that needs to be understood. So that's, I feel, the first barrier or the first challenge. The next point is this is a patient advisory council. So the key word here is the patient. As we say that you should not be there, wrong time, wrong moment, wrong place. Similarly, here you need to have the right person at the right place at the right time. So selection of an appropriate patient representative is a challenge. It has been found internationally, I was going through some literature, that, various Ivy League institutions, when they put out their calls for getting patient representatives on their PAC boards, they have a response rate of as low as 35%. So I think we can sort of extrapolate and understand what the situation might be like if we put out a call here in India where the concept is very new. And also we need to have a member or a patient who's motivated to understand, learn, be trained, and to do, to know what not to do. I think Lalu ma'am had that on her slide, a very, very interesting and I think a very important slide, that what they are not supposed to do. So it's not a place for being abrasive or being, confrontational. It's a point for liaison, for collaboration, for communication. So selection of the right patient, selection of the right member who would be able to understand the concept of a PSC, be willing to collaborate, be willing to travel for the meetings. That is something which is very essential. So drilling and making the patients understand their exact role on the PSC would be another challenge. The third big challenge, I feel, is to maintain continuity and consistency of the effort that's required in order to make sure that the outcomes that we get do not wane off with time. Because when we initially start something, of course, there is an initiative, there is an impact, and then gradually once it settles in, then we tend to find it difficult to repeat successes. So repetition and consistency are also certain keywords that are very essential to see long-term success. So there has to be a very motivated facilitator on the PSC who would ensure that the clinicians arrive for specific meetings, that the meetings are minuted, the agendas are addressed, whatever action points are, say, decided on a particular meeting, they are carried out. So overall, I think the major barrier or the major challenge is first for us to understand, accept that this is a concept which is not the future, it is the present. It is here and it is here to stay. And we have to start working on it, train ourselves, learn as we move along, and teach the others and take them along with us as well. I think these are the principal barriers, but there are ways to overcome them as well. Thank you.
Thank you very much for enumerating some of the major challenges and barriers. I think it is going to help the hospitals who are thinking of coming up with this, and they can keep all these guidelines in mind to make their PAC more effective and more result oriented. With this, I move on to Dr. Shalini, and as I mentioned already, she comes from a much bigger organization and a government setup where the number of patients, number of beds, number of employees are much more than many of the private, medium, small size entities. So the question to you, that what you have evaluated, what you have thought in your organization, which is going to be easier or setting up is going to be more efficient according to you? Is it like multiple patient advisory council in individual department level, or do you think one like an umbrella kind of setup for the whole organization is going to add more value? So over to Dr. Shalini.
Thank you so much. My organization offers a very unique background for PAC development. I think we have to understand that all government hospitals have two kind of patients. One are the rolling patients who come from different states for treatment and they just move on. And there are those patients who are from the adjoining communities. So for the rolling patients who are coming from different backgrounds, I think it will be better to have PACs in the individual departments. For example, in the surgery department, a doctor can sit down with all the patients who are being discharged for that particular day and take a feedback from them. And similarly, in the radiology department, all the patients who are coming to collect reports, few patients can be selected at random and they can be asked about their experience and what they would want to change in the particular department. So I feel, see, we have an OPD of nearly 10,000 patients per day. That's humongous. So, we have to keep in mind that we cannot choose patients, or we don't have the time to select patients. It is this kind of sampling that we have to use to study their thoughts. And then at the hospital level, we can involve the local community, which can, the community that can interact with other patients. And here I differ a little bit from what Dr. Sudeshna said. I think that we should establish these PACs in the context of the culture of the place and the mindset of the place. So in my place, I would, instead of calling it a PAC, I would, maybe call it a medical panchayat. And the chairman can be somebody from the community, call him a pradhan, give him a badge that he's proud of. Make it a matter of pride that he is part of this particular organization. That way he will make it big. This organization, he will go and advertise this organization to all his community members, so that, we can get more. They will come forward to, I know my patients. The moment they get a platform to speak, they will come and speak, provided they feel that what they are saying is a matter of importance. We have to understand that we are living in a very political environment. When patients, maybe they cannot make much of a difference, but they always have an opinion. So we have to just give them a platform and tell them that you have this platform to offer your opinion, and please do so. So that's one thing I wanted to say. And another thing is that we have to, like in an organization like mine, as I said before, we have to catch them at these customer touch points. Registration of births and deaths is another touch point that, you can take into consideration. So it's the idea is not very firm in my mind, but I've been thinking about it. And these are some of my few thoughts that I have presented just now. And I hope, I'm very sure Dr. Lalu will do something about it.
So thank you, Dr. Shalini, and I'm sure that over a period of time, when you think more and you will get the answer, and especially you gave a figure of 10,000 outpatients per day. I think probably that is the 1 month outpatient footfalls for many of the hospitals who are presenting and listening here today. And you told about the structure, you reminded me about the Panchayat Raj, you spoke about the Pradhan and all. So and you told also about the issues related to the political kind of environment. So I'm sure that we have to keep all this in mind and ensure that real Panchayat Raj doesn't come back when you create this kind of structure in your own hospital. So with this, I move on to Dr. Santhosh once again, that when we talk very outwardly that this is the positive point, this is the way we should do, but one thing I can tell you is there probably in everybody's mind, especially in the hospital administrator's mind, that when I create this, it should not disrupt my system operating model. It should not create some sorts of eruption in my operations, because you don't know how and when it is going to be, hitting you. So to give you an example today, when it comes in terms of declaring some of your infections rate, you feel scared to share with your own employees because you don't know who is going to tell outsiders and how it is going to be, reacted. Then similarly, if you talk something of your internal thing to this patient advisory council, if it is not handled suitably, it can boomerang on you. So according to you, that when you set up this patient advisory council, whether it can cause some sorts of disruption, some sorts of eruption in your operating system.
Yeah, thank you again. So I think this is one of the key apprehension the hospital administrator have, and they always keep on thinking about this, that what could be the different challenges. So apart from the lack of information about know-how about how to set the PSC, the apprehension about the disruption is one of the key things. And I think PAC itself, there are a lot of disruption I could visualize. And one important thing is like decision-making process. So I see that this PSC as a advisory council group as a kind of separate decision-making support system to the management, to the board, where the patient is representing all the other patient, and then they're trying to safeguard the interest of the customer. So in this process, we are always like tuned to make decisions in our own departments, and then at the hospital level, all the HODs are there, and then they formulate their decision making, their decisions. But with PSC having a mandate for providing the input for in decision making, I think it becomes very compulsory for hospital administrator that you take their either a patient is there in different departments and their inputs are taken, or the advisory council when departmental heads have defined or developed their different decisions and all that, their consult the expert opinion kind of thing for PSC is taken. So the hospital administrator has to learn and adopt to this kind of thing. I remember, like, I was when I was prior tenure, I was working with the World Bank, and we used to advise the UP government. So we had the consumer forum chairman used to come, and my health secretary and all that, they will be very apprehensive, because whenever the chairman of consumer forum will come, he will always talk about the issues raised by customer and very fanatic about the concern. So these government officials, they will very wary there, and they will not like the chairman to come and voice his things. So there are challenges, but we need to take it in a very positive manner. And of course, hospital administrator has to learn how to be more collaborative, and how to give their voice to them and utilize their decision-making process, the input into for decision-making process. The other thing is, of course, shift in priorities. So again, the department head has different decisions and all that, their priorities. But when it comes to the PAC inputs, they will give different kind of priorities. So priorities may change. I was reading a lot of case studies, and I found that in one of cases, the PSC said that, look, the hospital had identified a pain problem as a discharge thing, or lean, going for lean hospital initiative. But the PSC said, no, look, the appointment system for the follow-up cases, especially for the cancer cases has to be given a priority, because it causes a lot of problem. So ultimately, hospital had to think of, okay, how to give, rather than patient call for, in case of follow-up, rather than patient approaching to the hospital for making an appointment, rather hospital should, because we know who are the people and after when they had the last consultation. So the hospital had to find a team, form a team, and team used to contact the patient and then reschedule their appointment and all that. So shift in the priority decision making. And of course, if the priority changes, then resource allocation also gets changed. So hospital has to provide a separate or customized additional resources and all that for meeting out the improvements suggested by the PSC. If not, the PSC members will not be interested to suggest or make any kind of suggestion in the advisory committee. There are a lot of things I can think of. The one again important thing, as you have also identified, is about data privacy and security thing. In a group of internal group, you always take the name of the patient, take the doctor's name, and talk about that patient, that this happened to that patient and all that. This is how we heard. But when patient is there will always be apprehension that the patient might use this information and abuse the hospital, may bring the disrepute to the hospital. So some kind of mechanism, in fact, I would like to hear from you all that some kind of mechanism has to be developed, so that the privacy of patient and all the ethical issues can be handled. Resistance to change will be there. The hospital, especially the old one who resist to change, they don't hear sometimes their own bosses, senior people in the organization or thing. And when it comes to third person, if they say something, sometimes if it is a radical input, so adopting those inputs and changing, making the change, whether it is behavioral changes or systematic changes, is a big issue. So these are the things. There are many we can find out, but these are the few things I identified: decision-making process, priorities of the hospital, resource allocation, and of course, data privacy and security as the four important.
Thank you, Dr. Santhosh. I think we would have loved to hear more, but we are running short of time, and every good thing have to come to an end. So before I go and ask the last question to Dr. Nesha, I must say that these disruptions are always good for betterment for future. For example, today we are attending this in this digital thing. I think before COVID, we never thought and explored in this way. And that has resulted, when I was seeing in the chat box, the kind of messages were coming and from where all people have joined in this. I don't think that would have been possible if it would have been done through a physical mode where the number would have been very much restricted. Secondly, you told about data, and we are really very much careful because the data security bill has been passed, and there they say every breach can lead up to 250 crores of penalty. as on today declared as per the bill. So we have to be very careful. So with this, I move on to the last question to our international expert, to Dr. Nesha, that, we have spoken what is happening here and some of the international example, but when we are starting this journey and we are trying to get it implemented in our country, if you can give some of the suggestion and steps related to in the ground level to initiate this formation of patient advisory council, just maybe in a couple of minutes, if you can just touch upon what are the do's, don'ts, and what are the steps to be taken. You have to unmute yourself.
Sorry. Thank you for this question. I would like to use my slide for this. So while setting up, your PAC at the hospital, although we have got a beautiful roadmap, which is there at the international level, there are still more references which are available. So the first step, in my opinion, can be, assessing the existing practices. Maybe you are already halfway, like, many hospitals have already introduced many initiatives, like We Are Listening. There are multiple focus groups which are there, So maybe you would like to see that at what stage you are. Create your storyboard, aligning, how you can enhance these activities and transform it to the PAC. Then meet your leadership for their approval and sponsorship. What I mean to say is that, when you approach your leadership, do not go empty hands. You should be coming back with an approval, and you should be coming back with a yes. So create your storyboard, how you're going to express your ideas, how you're going to align your existing activities, because each and every hospital today is doing something or the other to enhance on patient experience. Every hospital is trying their best to, enhance on patient safety, whether it is a rural hospital or an urban hospital, corporate or government hospital. Initiatives are happening. Just see how you're going to align it. So once you have a leadership approval and the sponsorship, the concept is agreed upon, you can use multiple tools to create your formal PAC forum. There are multiple references available from AHRQ, IPFCC, which includes a handbook and a template for a work plan also. So using these guidances, you can further select your PAC members. For us, I would say for the entire group over here, we already got the guidelines from CAHO, and that can be the best starting point, I would say. And if somebody wants further references, reading materials, I've put down a few links here in the slide. You can go through and look at it. Okay? Then the next is to have, meaningful engagement and involvement of the stakeholders. And these activities, when planned, we should keep in mind that, we are able to sustain it. Many times we start with a very big bang, but then again, taking it forward becomes our own challenge. So have meaningful engagement activities. Okay. The most important thing for the quality managers, I would suggest, is to add this initiative as a part of your annual service excellence or a quality improvement program, so that you have a sustainable roadmap that can be evaluated and it can be improved. And lastly, do remember to thank, pat, and celebrate your success. So that's all I want to say. Thank you so much.
Thank you very much, Dr. Nesha. And I must say it was a great learning, not only for me, I think all the people who are attending this, and we have gone much beyond the time schedule. So I'll not take much time from all of you. And before I am thrown out from this call by the admin of this group, I must say that it is really, really made a solid foundation for this launch of this Patient Advisory Council. And I can see such a huge emotion, such a huge kind of involvement and participation. I think that is going to really motivating all of us. So with this, I want to hand over to Dr. Lalu. Wish you all the very best. Have a great evening and have a great weekend. Thank you.
Thank you. Thank you so much, Joy, sir. Let me tell you, brilliant session. You moderated it so well. All the questions were very, very appropriate. And, it complemented the session so well. All these questions and the answers by the panelists, brilliant. Let me tell you, it's been a brilliant learning experience. There's so much of talent in this country. It's just a matter of bringing it all together. And I think at CAHO, that's what we are good at. Getting all of you together, getting everybody together and together we are a success. And this is certainly a great team initiative. And I really appreciate all of you for taking your time, joining, for preparing so well. In almost all questions, I am sure the participants would want to raise have all been answered beautifully well. And I now open the forum for discussion, maybe just another few minutes, just 3 to 4 minutes. And if anybody has any burning questions,